tell me a little bit more in detail in the bill about what excess revenue means. It says that if they make excess revenue at the and explain after, or just explain that first.
Sure. So the excess revenue, what is being indicated there is that so when a budget is agreed to or performance improvement plan, that part just applies to the budget review part. So we're pretty far down the road at that point. Excess revenue would be, okay, so you've entered into a budget agreement with this board and the hospital exceeds it to some degree in it, and the bill provides numerous ways for the board to sort of handle that situation, right? One way is to sort of roll that over into the next year's budget if there's a miss. One way is quite frankly there's actually mechanisms in there to reward them for performing better than others. I think the provision that's giving you all pause is the mechanism that would allow the board to call some of that back. Representative Ramon's nodding, and as I thought I was trying to have a dialogue with one of your colleagues, and I apologize if it seemed like that was contentious, but I was just trying to explain that some enforcement mechanism is needed. Otherwise, targets could continue to be missed with really no repercussions for the health system.
When this board looks at excess revenues, will it also take into account the costs that the hospital has incurred?
Yeah, so the data, if you look at the data that's being asked to be submitted by the entity, it includes all that to try to take all that, and we're trying to get a complete picture, and we're trying to set up a system where, in the event that this board would have additional questions and want to dig deeper in certain areas, to try to figure out what cost drivers are, to try to rationalize and understand really the situations being faced by these entities, so they would have access to that data. And I understand some of the opposition to doing that, and that's been stated, but what we've really tried to do is give this board the tools that they need to be as thoughtful about this as possible, and we've also given them quite a bit of capacity to make decisions based on what they're seeing, as opposed to binding them very tightly to statutorily sort of predetermined positions and decisions.
Okay. Now, this bill does give the authority of the state, or I guess this board under the state, to is it 3 years down the road? It gives the authority to this board and the state, if there is excess revenue, that they can take that excess revenue from the hospital.
They could, sir. That's one of the options. But again, what that's used for, Representative, is you need, again, I guess I'm really not explaining this very well, because without that provision, without some sort of clawback, without some sort of mechanism to, have some sort of a financial penalty, which, quite frankly, my friend at the Healthcare Association mentioned as an option for this to enforce this bill, you would have a situation where they could continue to ignore year over year the budgets that are agreed upon with no repercussions to that.
And I understand exactly what you're saying. I guess I'm not making myself clear, or to other people in this chamber, is we're giving the state authority to take money from a private business when they make excess revenue. So we're giving the state authority through this bill to take money from a business when they're doing well. That's exactly what we're signing off on here.
No.
I understand that you're saying it may not have teeth if we don't put in here, but that's what we're doing by saying yes to this bill, is giving authority to the state to take money from a nonprofit when they do well. That's exactly what's happening here.
Representative, could I?
Sure.
Thank you. Yeah, and I think that you're getting at kind of the point of why we're here, which is what's been years and years of sort of unchecked doing very well, making more revenue year over year, making revenue that outpaces inflation every year, and the strain that that's having on the rest of the economy at large. Yes, these institutions are doing very well. They're making a lot of money, and that's great. And I think it's led to some amount of, good investment in their own facilities. But the question is, how much of our economy can we allow this industry to take on and become a larger percentage of, until we start recognizing that their continued growth and continued success, as you're putting it, is having a negative impact on state budgets. It's having a negative impact on small business budgets. It's having a negative impact on the budgets of Delawareans who are paying more and more for their health care.
I don't agree with that. But
it's in the data.
My follow-up question is, once this money if we're giving authority to take this money when it's excess revenue, where does this revenue then go? Where does the state put this revenue?
So right now, it's established to go to a fund to help invest in health activities, and I think the speaker could answer a little bit more about that provision of the bill.
That's my question. Where does this, if this board takes this revenue, where will this money
So
go?
as the bill stipulates, I think it would stay in the Treasury Department. We had some conversations about that, but it would go to a fund to invest in community health projects.
And what is the definition of what a community health project looks like that it can be spent on?
I don't believe the bill gets to that level of detail, sir.
Okay. So what we're saying here is if this money is, well, we're giving authority for the state to take this excess revenue, that the state knows how to better spend this excess revenue in our communities than the hospitals that actually employ hundreds of people and serve thousands of people in our community.
I mean, there's an assumption that excess revenue is being used to do the point that you're making by the hospitals.
It definitely is. I can tell you in Bay Health in Milford, it's spent very well in our community. And now we're saying that the state knows how to better spend that excess revenue than our own nonprofits do in our community. That's what this bill is saying right here.
Where does it say that in the bill?
I'd like to move on to the benchmarks.
Sure.
Are you done with the witness?
He may be able to answer the benchmarks. I'm not sure. So, under this bill, first of all, can you answer? And please, if this isn't for you, we can let him go. But where are the benchmarks coming from?
Sure.
That are established by this board.
Right. So right now, the benchmark program was established in 2018 under an executive order. It was then put into statute by the General Assembly in 2022, I think. That is determined by a subcommittee of DFAC, the Healthcare Benchmark Subcommittee of DFAC, and they have a methodology that they've determined on their own. That part's not in statute that they use to set the benchmark.
Okay. And who's regulating these benchmarks?
So they set the benchmark, DFAC does, and then the department has, there's a benchmark. The benchmark is housed in the Healthcare Commission, and every year they measure the total healthcare spend in the state to compare it to the benchmark.
Okay. So under the, and please correct me if I'm wrong, but how I understand the bill is if the hospital does not meet the government benchmarks, the government can take over the financial management of that hospital.
They have, so you're kind of skipping to the very end in a process that assumes there's absolutely no progress and positive, I guess, movement that the board would deem it necessary to start marking up a budget. But yes, sir.
I understand that, but again, we're giving the authority to the state government to say if you don't meet our benchmarks, then we have the authority to take over the financial management of your business.
Hey, can I just, I mean,
Yes,
this may
go
be a
ahead.
distinction that is not received very well by you, but these would not be state government employees, these would be board members. So these wouldn't be like full state government employees. It's not like, somebody sitting at the Department of Health and Social Services is making that decision. But your point is
But they're
received.
appointed by the governor and they're paid for by the state of Delaware.
Yes, sir.
Okay. My question with that is I don't know, but who would be running the financial management at this time? Who would take over that financial management?
So the board would be the entity that makes the final decisions on that sort of thing, whether to enter into that, what to do with it, and that sort of thing. The fiscal note of the bill assumes some analysts that would exist at the Healthcare Commission who are state employees, and some contractual services to help, with the work of going through the documents and informing the board members about the current situation and what the financials say, so that to help them make a decision.
So would the board, along with its analysts, be taking over the financial management of the hospital if this was?
They would
went
not
down
be
the line?
taking it over in the sense that they wouldn't be, they wouldn't be originating a document. And I wonder if they wouldn't be the ones, say, sitting down and saying, we are now going to write a budget for this particular healthcare entity. They'd be receiving the budget, and they would have the opportunity to go through it and obviously revise the budget as it's stated here. In the event that we get to that endpoint, and again, I think this is a hypothetical that, again, is you're latching on to sort of what is kind of needed for any real accountability to be maintained in this entire process, is at some point there needs to be some ability for an enforcement piece in all this.
Well, I have to disagree. It's not a hypothetical. We're giving authority to our government and to this board to determine what the excess revenues are, to take away excess revenues, to put it into a fund to be used for community and say that they're going to spend it better than our hospitals are. And we're giving them the authority under this bill to create the benchmarks and take over the financial management. So yes, it may be, a third step, and it may be that you don't want to use it, and it may be that you have to put this in there in order to have some teeth in the bill. But by saying yes to this bill, we're giving authority to the state government to do all these things.
But I guess here's one response I would have to that, Representative, and I do appreciate where you're going in this. And I think part of the other challenge that we're having here, and why we find ourselves talking about healthcare so much, particularly healthcare finance, it spills over into everything, sir. This isn't a situation where the decisions made by the hospital and decisions made by the organizations that pay them a certain price for their services are limited to just impacting the financials of those two particular parties of the contract. This is much larger than this, right? The decisions made by a hospital and an insurer have an impact on individuals, have an impact on small business, have an impact on the state government. So the idea that this just continues and that the state has no sort of, rationale for being involved in such a process that affects all of our taxpayers, all of our citizens, all of your constituents in this room, all the businesses that operate in our state, I think that that's what this is about. It's about a seat at the table for individuals whose priority is the taxpayers, priority is the residents of the state, and not necessarily their own bottom lines.
I would argue that this isn't a seat at the table. This is definite government overreach by putting authority into this bill of taking over the hospitals if they deem necessary. The government overreach in the healthcare industry in Delaware has actually increased the cost of our healthcare industry here. The state of Delaware has put into practices here that have diminished competition in Delaware. And the competition is what is going to drive down costs and bring up the quality of care. And we've done things, this chamber has done things to diminish that competition and allow for not only certain...
Point of order, is there a question here?
Yes.
Mr. Acting Speaker?
Representative Bomback.
Yeah, I'm not hearing a question for the witness.
Sir, do you have a question for the witness? If not, we will move on.
I thought this was a good exchange, Representative.
Let me see. I'll save my comments for later. Yeah, thank you.
Thank you. Representative Smith.
Yes, thank you, Mr. Acting Speaker. I have a ton of questions. Representative Bomback won't have to worry. First off, Madam Speaker, I think you've always admired your stick-to-itiveness on all of this type of stuff. We've worked on a lot of things together, so none of these questions are a shot at you. It's just more general understanding for everything. One of the first things we kicked off was by saying, in the same statement, it was said hospitals won't submit their budgets unless they don't hit the benchmark, but then was also said they will submit them annually. Can you just confirm which one it is? Sure.
All right, in my opening statement?
Yeah, you mentioned, I wrote it down, it's been a while now, sorry. You said hospitals won't submit their budgets unless they don't hit the benchmark, but then also counterintuitively said they'll submit the budgets annually, and I was just wondering which one of those it is. Either.
So they will submit their budgets annually.
They will submit, okay.
Yes.
Thank you. In regards to, look, first off, I think this has been a good exchange. I don't think there's anybody in this chamber that doesn't think we shouldn't be lowering costs and raising quality. So let me start there. I think we're all in the same place when it comes to that. And I think there's a lot of forces at play that come to some of those things. I also think there's a lot more we can do, and I'll offer a few suggestions later. But I guess first, can we start with how are the unique characteristics of different healthcare providers addressed in the benchmark process?
Say that again.
Sure. How are the unique characteristics of our different health providers in our state, Sussex County, Kent County, Newcastle County, we have different providers, small, large. How are they addressed in the benchmark process?
That I would have to go to David Betts again.
Sure.
He's our benchmark
as I ask
expert.
questions, it doesn't matter who answers to save time.
Hi, Representative. How are you?
Oh, hi, good to see you. Is it weird that you're still here right now?
Yes.
Okay.
So the benchmark is what it is. It's not sort of, doesn't stipulate, the benchmark shall be one thing for one entity and another for another.
Okay, so is, in regards to that, one of the things I've talked a lot about recently and appreciated Representative Johnson and Senator Mancivino, it's bringing up the aging caucus, because that's one thing we've been dealing with and I think is going to only get exacerbated very badly over the next 5 to 10 years. Is any of that, those kind of complexities, patients living longer, greater incidence of chronic disease?
Sure.
Is that in the benchmark at all?
It's not in the benchmark, sir, but it is it will reveal itself in the data that gets submitted.
Okay.
If you look at the list of data that
Okay.
they would be required to, the reason why that's as extensive as it is because we would obviously need to see that to be able to make the board. I say we. I'm not going to be on there, but the board would need to be able to see that level of detail in order to suss that sort of stuff out.
Okay. Changes to the benchmark that address inflation. Does that happen?
So the benchmark subcommittee sets its own methodology,
Okay.
sir, and the extent to which at any time they can sit down and decide to revisit their methodology. There's been discussions in the past. It's still what it was when it started.
So they haven't
They
addressed
have not. So right now they are actually at the point where they're deciding what the next year's benchmark is going to be. That decision should be coming soon. At any given time like that, they can have a conversation about, do they want to tweak the methodology?
As an aside, as a point, we deal with a lot of bills in this chamber that actually have very similar values and issues. Representative Baumbach, Representative Collins, and Representative Ramon all had different tax bills to change different structures, and one dealt with inflation too. I just think if we do one of those things, I kind of mentioned in last week's debate, I think we just need to be more consistent on how we're affecting our constituents in that way. Moving on to kind of the workforce side, I love that side of it. I do think Delaware should have a medical school, so I'll just say that on the record. If there's any hospital system that doesn't want that, I think they should get to the table and help support that, because that would generally help that, because then if you get the placement, you're more likely to stay in the state, so that's just a natural progression. Kind of like the speech language hearing program that our speaker has helped champion. They come from all over the country, which makes them stay because they're from all over the country, meet their spouse, buy a house, do all the things that we like as people that collect tax money. So anyway, that's an aside. And the governor's fiscal 25-year recommended budget includes pay increases to address the vacancy rates in state agencies because we're feeling the same pressures. How will the benchmark process impact hospitals' ability to recruit and retain talent, similar to what we do here? One of the things, before you answer, one of the issues with all of this is we're clearly having labor shortages for other factors. One issue I have with the bill is potentially for this to also create scarcity. So I was just wondering if you could address that.
So the benchmark, can you just sort of clarify again one more? Because you said something about it affecting workforce.
Yeah, so
Does it account for workforce shortages? I mean,
Yes.
The benchmark is an economic measure,
Right.
Representative, so it's about, and I can put some...
and labor shortages
sure.
are an economic
And
one.
I can put some context as to why it's, it's been stated that, this is a healthcare benchmark, not a hospital benchmark. So the point of it being calculated the way it is to try to get at the fact that healthcare costs continually outpace economic growth and inflation, right? So the fact that the benchmark itself is not a measure of, say, healthcare inflation year over year is because the whole point is to sort of try to bring those two numbers into some sort of harmony so that it doesn't lead to an unsustainable sort of growth in the healthcare costs. Because if it outpaces the economy, if it outpaces inflation, it's going to continue to chew up a bigger piece of the pie.
I wish you were giving testimony during the minimum wage debate. Same argument. All right, thank you. Quality of care, that's one thing that I think we talk about on the other side of it. So what mechanisms are in place to ensure that the quality of care won't suffer under the bill?
There are lines in the bill that talk about that,
Yeah,
right?
a little bit.
And we're trying, it is a little bit, but I think it's really important because it's the part that directs what the board needs to consider.
Okay. So can you kind of go more into, I know it's going to be by governor appointment. That's a little scary to me. I'll be perfectly blunt with you. Having one person having the power over who those are. And I'm just going to give you an example. Myself and Senator Poore were on the bill to, everyone called it break up DHSS. That was not the intention of it. It was more to categorize it in different areas so that, for contracting and other reasons, folks with disabilities versus folks in homes and others could be managed better, more efficiently. In that was by appointment as well. And there was a gentleman appointed to that was strictly appointed there to stop us doing it. And we wasted 6 months of our time. And I knew just on day one that was going to happen. So kind of what are the criteria in place? Do you have to have, a healthcare finance background versus a medical background? Me personally as well. The conflict of interest piece in the state of Delaware is really kind of funny because you're either married, dated, or friends with somebody. But I'll give you a great example, and someone I greatly respect, and I know you greatly respect, and probably everyone in this chamber, but former Secretary Rita Landgraf, right? She's on the board of Christiana. She's also on the board of Highmark. It seems to me we do have the right person who we all know cares about people and doesn't have to be doing any of those things, let's be honest, still doing it for the right reasons. So how does this change kind of the people that are already at the table?
I'll have the legislation in front of me, so I'll just
Cool,
go.
thank
I'll
you.
just go to line. We did put qualifications in there, which addressed your issue. They have to have knowledge of healthcare policy, healthcare delivery, or business, finance, or accounting, knowledge and experience of characteristics that complement those of remaining members of the board. Impartiality and the ability to remain free from undue influence by personal, business, or professional relationships with any other person subject to supervision of the regulatory of the board. So there's a list. We made sure that we put qualifications.
And I get that, but if it's politically appointed, how does that happen? How does that reasonably happen?
Representative, and I want to get, because this was a part that actually was another sort of result of conversations we had with hospitals and the criticism that these were sort of completely unscrutinized people who were being put up there as a result of how the bill was originally written.
Okay.
So the thought process here, and I don't know it's the speaker's thought process. It was her piece of legislation, her decision. But ultimately, whether or not these individuals meet those criteria and those qualifications are sufficient, before there wasn't anything. It was just that the word of whoever the appointing individual was, whether the Speaker of the House, the pro tem, the governor. Right. Now there's scrutiny through the Senate confirmation process. So the political dynamics being what they were, I mean, the thought process was that at least there would be a review and a conversation with that individual to try to suss out whether or not they met those qualifications.
Sure, and I said something as a joke over here earlier when we were talking about that during Representative Duke's comments, but like political equity, there's no Newcastle County Republicans in the Senate, so I don't even know how you can deal with those questions properly when it comes to one of our major hospital systems. That's an aside. I appreciate it. Where will the savings come from? How do we know, how can we know 100% today, if we vote on this, that it's not going to lead to undertreatment, reduced patient satisfaction, adverse healthcare outcomes in order to meet financial targets? That's a really hard question to answer. I do think it's the intent, so I don't want to disregard that. I believe everyone has the right intent here, but how do we know? Because at the end of the day, I don't want to do something just to get it right when, for instance, There's also the counter debate of if we should have an inspector general. There's also the auditor of accounts. So why couldn't we just simply say that any hospitals and anyone who gets state dollars can be audited within a certain period of time if we think there's impropriety or questions, whatever it may be, or counterintuitive, if we do the inspector general, why wouldn't it just go through that office versus creating another board? Because my point then goes back. I do think some of the people that could be appointed to this board that I think are high regard in the medical community are already involved. And so I just, again, respectfully, I get what you're trying to do. I just don't see how this changes that.
Sure. Would you like a response, sir?
Yes.
Okay. So couple thoughts come to mind. One is we actually really have no way of determining right now when cuts are made by a health system that they're not also doing what you're afraid may happen here in the review. What this provides is a level of transparency and a level of, honestly, this board will have accountability as well. And one thing that we've seen over the last couple weeks is that the entities that would be subject to this board are very good at organizing and making their point well heard. So in the event, so the idea that there wouldn't be accountability on what that entity is doing to sort of review their budgets and maybe make changes to it is, I think that we can be very confident that there would be quite a bit of scrutiny on the decisions that they were making. So I would say I don't think that this, how are we preventing? There are, like I said, some safeguards. There will be public scrutiny on this process. It is open. And then additionally, I would just say that we actually don't know right now, because we don't see this stuff, that when they do make cuts, that it's not having the same impact that you're worried about maybe occurring with this board.
Okay, thank you. How are other healthcare trends taken into account under this legislation? Some of the ones written down, insurance-related issues, for example, high deductible plans, denials of coverage contributed to financial burden on patients, healthcare providers, increased overall healthcare cost.
Sure. So a couple things that I think, one is, again, that's the robustness of the data submission piece, but then also what, this will not end at that point. This will not be a situation where data is submitted, this board runs off and makes decisions, right? There will be ample dialogue with the entities as well, where they can make cases for why they made certain decisions that they made, why some of these other impacts that you're talking about, that they can clarify, outside the scope of what we are able to control, things like that, to try to have, this truly is designed to try to give this board the ability to make sophisticated decisions based on very complex data and very complex conditions.
No, understood.